Welcome. My name is Dr. Jillian Rigert. I'm an oral medicine specialist just completing my third year as a researcher in radiation oncology. I had the honor of being a speaker at an event that just happened on June 27th, 2024. It was the Do a Good Job Symposium. It was created by Dr. Parul Dua-Makar, who is the sister of Dr. Manu Dua. Dr. Manu Dua was a dentist who unfortunately passed away at the age of 34 from oral cancer. His birthday was on June 27th, which is the significance, the date of the event. The symposium was incredible, extremely informative, with over 20 speakers helping to empower healthcare professionals and patients to save lives. Dr. Dua-Makar has given me permission to share my session from that symposium to give you a glimpse of what you can expect, though the topics were quite broad and it was so valuable. And if you miss the event, you're in luck if you're watching this, 2024, because the recordings will be available until the end of the year. So if you are a healthcare professional or a patient who may benefit, you can check out more in the description down below. For the rest of the video, I will share my session, which was on the quality of life and psychosocial impacts of head and neck cancer treatment. I hope you may find it informative. And as a disclaimer, conversation is for informational purposes only, and it's not to be taken as medical or dental advice. Please make sure that you work with your healthcare professionals for your treatment, as you are unique and so is your care. And now, on to the session. Hello, my name is Dr. Jillian Rigert, and today we'll talk about the quality of life and psychosocial impacts of head and neck cancer treatment. Before we dive in, I do want to report that I have no financial disclosures, and this conversation is for educational purposes only. Please seek individualized care from your medical professional team. A little bit about my professional background to provide context for this conversation. I'm an oral medicine specialist, and if you're not aware of what that is, it's a specialty of dentistry, and we help manage the oral manifestations of systemic conditions such as head and neck cancer. I am currently finishing a 3-year postdoctoral research fellowship in the Department of Radiation Oncology, Head and Neck Division at the University of Texas MD Anderson Cancer Center. So why is this so important? As an oral medicine specialist, I see patients before the radiation therapy and after the radiation therapy. And before the radiation therapy, we work to help patients to prevent any negative impacts of their treatment on their oral health. But what I was noticing after treatment is that patients were consistently coming to me with quite a bit of distress, saying that the treatment side effects, such as the dryness of their mouth, were drastically reducing their quality of life, their capacity to eat, their desire to socialize. And they were telling me that due to those side effects, they just didn't want to live anymore. And so it made me wonder, how can we prevent these side effects and improve patients' quality of life and support them so that they aren't feeling so much distress and have a higher quality of life after their cancer treatment? Head and neck cancer includes all forms of cancer of the head and neck, which are more than just oral and oropharyngeal cancer. But for today, we're going to be focusing on oral and oropharyngeal cancer. Historically, when we think about oral cancer, we think about tobacco smoking. And if you smoke tobacco and you drink alcohol, you elevate your risk for cancer even more than tobacco alone, because that alcohol acts as a solvent and brings those carcinogens from the tobacco into the tissues. But now what we're seeing is this rise in cancers associated with the human papillomavirus. And the high risk strains are sexually transmitted and impacting patients who are younger and healthier. And these tumors respond to radiation treatment quite well. And what that means is that patients are surviving longer with the treatment side effects. And the ways that these cancers are treated are from surgery, radiation, or systemic therapy, such as chemotherapy and immunotherapy, or a combination of these three. And so we'll briefly talk about surgery and chemotherapy and a little bit more deep on radiation therapy, as the radiation therapy has the side effects that are most often associated with the distress after treatment. So, cancer treatment goals in general are focused on controlling the tumor, improving survival, and today we'll be talking about really optimizing patients' function and quality of life. When it comes to surgery, each patient will have an individualized treatment plan. And it's important that the surgeon and the patient talk about what to expect during the surgery and after. What are going to be the site morbidities where that tumor was? If there's a plan to do some grafting from a donor area to bring tissue to the site where that tumor was, what can the patient expect in the changes of the way they look and the way they function? And it's important to be real and support the patient in really preparing to what changes might happen, as these changes are associated with increased body image distress. Radiation therapy can cause a host of different side effects. Very common is dry mouth, or also known as xerostomia, and that can come in various degrees from mild, moderate to severe. And dry mouth is that subjective experience of dryness of the mouth, and it doesn't directly correlate with the reduction in salivary flow. Patients who start off with higher saliva and have a drop about 50% might say their mouth feels more dry than a patient who came in with dry mouth and their mouth still feels dry. The issue with dryness of the mouth not only is the discomfort, difficulty eating, some pain, but the impacts on the oral health might include increased infection, increased risk of decay, and detrimental impacts long term. So, radiation therapy has changed over time to try to protect salivary gland tissue and reduce the damage so that patients may maintain salivary flow. And this isn't always possible because the treatment will need to aim at the tumor. And sometimes those salivary glands are in the direct path and have a lower threshold for damage than the tumor itself. Oral mucositis often occurs during treatment, and that's inflammation of the soft tissues in the mouth, which can start as a redness and potentially form ulcerations that can impact eating and drinking. So your treatment team will help support you through both with topical based modalities and with potentially systemic pain management. Taste can be impacted from radiation, and this can be detrimental on quality of life. And unfortunately, sometimes those tastes doesn't come back. So we're trying to prevent that damage, and there's more research being done on what exactly happens and what's impacting these taste buds so we can try to improve the amount of patients who are noticing taste changes that are detrimentally impacting their quality of life. Radiation can cause what's thought to be potentially direct and also indirect damage to the teeth, and these form in a characteristic type pattern on the neck of the teeth and the top of the teeth, which is different than decay that forms from the normal bacteria in your mouth and diet. And to prevent these radiation carries, the oral health professional will often prescribe high dose fluoride and fluoride trays. And the fluoride helps make the teeth more resistant to decay because it hardens the enamel structure more than your enamel is at baseline. A less common but often morbid condition that might develop from radiation therapy is osteoradionecrosis. And this is death of the bone related to the radiation therapy, which is associated with the dose. And often, if it develops, will affect the back of your lower jaw because at baseline, that area has lower blood flow. This risk is often increased if you have surgery in the area. So we often try to remove any teeth that might cause a problem and need to be removed in the future. We often will suggest to do that before your radiation therapy. And we're really mindful on making sure that the patient maintains improved oral health and systemic health to reduce the chance of osteoradionecrosis in the future. Radiation dermatitis is the impact of radiation on the skin, which can be acute and also potentially form fibrosis and have long-term damage. Lymphedema is when the fluid isn't able to drain through the normal lymph tissue and can swell up in areas of the soft tissue. Trismus is a reduction in mouth opening that can happen from tumor infiltration, inflammation, or fibrosis. So we're really mindful to know what's causing this trismus and how to best treat it. If it's a tumor, we want to treat that tumor. If it's swelling, sometimes it can be reversible, but if it's fibrosis, that's more difficult. So we want to try to prevent that trismus from happening. That might include passive stretches at a time where you're not having so much pain in the mouth so that you can maintain those exercises without increasing damage. Dysphagia is difficulty swallowing, and often difficulty swallowing can come from direct damage to the swallowing muscles or atrophy if you're not eating by mouth during treatment. So typically a speech language pathologist will work with you and assess your swallowing and give you recommendations to how to reduce dysphagia safely. Pain is common, and this type of pain might be neuropathic or nociceptive type pain. And you'll be working with your treatment team to try to prevent the pain and manage it at the level of which is occurring. Because what we want to do is make sure that your pain is managed so that you can maintain nutrition. And if you maintain nutrition and oral hygiene, that can reduce the severity of all these symptoms and reduce the risk that some of these ever develop. Chemotherapy side effects are going to depend on the drug. Some of these often are GI distress. Again, mucositis happens that when I see it typically is when the blood counts are lower. You can have injuries to organs such as the kidneys, feel really tired, potentially develop peripheral neuropathy. So the person that will help you or the team is the medical oncology team. Go over your specific medication and potential side effects that you might expect. So, what's under discussed is really the psychosocial aspects of head and neck cancer and its treatment. And this includes anxiety, depression, PTSD, body image distress, loneliness, suicidality, and financial distress. And a lot of the psychological factors are often under discussed because some of the symptoms are confounded by the expected symptoms from the treatment itself. So, teasing apart what's anxiety, what's depression, what's related to the treatment, what will go away, what needs to be managed can be challenging. And so, I just really want to bring awareness to what patients are experiencing according to some research and how we may better support them holistically, because having anxiety, depression, these PTSD, suicidality can really impact a patient's quality of life, desire to live, and their acceptance of treatment and how they follow up with their treatment plan. Psychosocial distress, as defined by the National Comprehensive Cancer Network, is an unpleasant experience of psychological, such as cognitive, behavioral, emotional, and social, spiritual, and or physical nature that may interfere with one's ability to cope effectively with cancer, its physical symptoms, and its treatment. Psychosocial considerations for the head and neck cancer population in particular include smoking, heavy alcohol use, depressive symptoms, anxiety symptoms, and severe psychological distress, such as PTSD, the body image distress, and potentially suicidality. Some research have suggested that about 29 to 56% of patients may continue to smoke following head and neck cancer treatment. And that's highly correlated to the presence of a pre existing psychiatric condition. If we think about the role of tobacco use, it's often a maladaptive coping skill. So we can't just address the tobacco without addressing the reasons why they might be using the tobacco. It's really important to provide care at a holistic level, because if we treat the other conditions that might lessen their tobacco use, especially if we're providing them with different coping tools. For patients who continue to smoke during treatment and after treatment, it's associated with a decreased prognosis, increased risk of recurrence or a secondary cancer developing, and increased psychological distress. So, despite them potentially using tobacco to calm their nerves, it actually can lead to an exacerbation of anxiety and depression symptoms. And the prevalence rate of anxiety and depression in the head and neck cancer population is hard to estimate. It might be underreported because, as I was saying earlier, it's confounded by some of the symptoms correlating to anticipated treatment side effects. But it's estimated that about 30 to 50% of patients with head and neck cancer experience anxiety and depression. And these conditions are associated with decreased function, decreased quality of life, increased healthcare utilization, higher financial burden, and a negative impact on survival. To support patients, it's really important that we counsel them so that they know what to expect and we really ask what they need individually. They can be referred for cognitive behavioral therapy and problem focused therapy. And some patients might benefit from psychotropic medications, or some studies that have suggested that using low dose escitalopram prophylactically can reduce depressive symptoms for patients at high risk. So, as I noted earlier, patients might develop body image distress. And it's difficult for head and neck cancer patients because we often identify who we are through our face, and that's a very visible feature. So, what is body image? Body image is a dynamic perception of one's physical body, the way it looks, the way it functions, the way it feels. And when you have body image distress, the way it might feel is similar to physical pain. And patients who might have been judged or bullied for their appearance in the past might be really sensitized to this type of experience. So, we want to make sure that we're being realistic with patients about what they can expect the changes or treatment will be and support them and provide them counseling and referrals to mental health professionals as needed so that they can really process through all these changes and learn how to accept and adjust along the way. Patients with head and neck cancer and their caregivers are at increased risk for post traumatic stress disorder. So, according to the DSM 5 criteria, this disorder requires being exposed to a traumatic event, such as cancer, either directly or indirectly. Symptoms may include intrusive thoughts or re-experiencing of the traumatic situation, and that can show up as physical sensations, emotional responses, or nightmares. Patients and their caregivers might start avoiding things that are triggering or numbing themselves around triggering events. They could have negative changes in mood and their ability to think and their memory and increased startle response, and they might have difficulty with functioning. And according to the criteria, these symptoms last more than 1 month. So, some research has shown that 12 to 33% of patients and 19 to 29% of caregivers develop post traumatic stress disorder. This will change depending on when you're evaluating it in the acute and longer term, those exact numbers. And if patients come in with a maladaptive coping skills or their caregivers have maladaptive coping skills at baseline, they're at higher risks. And interventions include psychoeducational counseling, which is a big theme, making sure patients understand what to expect so that they can process through in a timely manner, and providing support group referrals and refer to a mental health specialist for individualized treatment, which includes targeted trauma based therapy and supportive medications for symptoms. As I mentioned, it's not just the patients who are affected by the cancer. Their caregivers are also at increased risk for PTSD and other negative impacts on their mental health. Often they might experience decreased interpersonal communication and intimacy with their loved one who has cancer, and they're at increased risk of morbidity and mortality because as they're caring for someone else, they might be neglecting their own overall well being. And I do have a good friend. Her name is Dr. Delia Caramonte. She's an integrative palliative physician who's very dedicated to helping caregivers support their loved ones. And she has just written a book. I have no financial connections with this book. It's just a lovely book with a person who I think is doing a wonderful job supporting patients and their families holistically. It's called Coping Courageously. It's a heart centered guide for navigating a loved one's illness without losing yourself. So that might be a good resource to check out if you are a caregiver that's looking for support and to know you're not alone and what you're experiencing is completely valid. And it's important, again, to take care of yourself in order to be able to take care of others. Easier said than done, I know. Unfortunately, in the US healthcare system, there's a lot of financial toxicity related to healthcare. This impacts about 40 to 59% of patients with head and neck cancer, and it's from the out of pocket costs, which might lead to medical bankruptcy, from opportunity costs, such as missed work, reduced income. Some patients have professions that once they've had cancer treatment, just speaking or things that require a lot of interpersonal communication, they may not be able to continue the jobs that they had before their treatment, which impacts not only their income, but may lead to grief and challenges with their identity. Having financial toxicity might lead to declined treatment. If you're having some financial insecurities, it can lead to skip medications, increased symptoms, trying to power through the symptoms without medical support, and might worsen patients' prognoses. So, to help patients financially, there are programs and organizations available, some of which include the Head and Neck Alliance Program, the Oral Cancer Foundation, support for people with oral and head and neck cancer, cancer care, and the Assistance Fund, to name a few. So, seeking out those opportunities, and maybe a social worker can help patients and their families to look into what resources might be available for them. We also want to be mindful to utilize our healthcare resources appropriately and not put this financial burden on patients if it's not necessary. Unfortunately, head and neck cancer patients have one of the highest risks of suicide and suicidal ideation compared to both general population and patients with other types of cancer, often related to all the things that we've been discussing today. So we want to make sure that we're screening these patients with a validated screening assessment and have a workflow in place for appropriate referral. Interdisciplinary and multidisciplinary collaboration is essential for patients with head and neck cancer and supporting their caregivers. So, interdisciplinary collaboration is this communication amongst all the specialty teams and the patient. So, we really want to make sure as much as possible that the treatment teams are working together, which is often easier if they're in the same institution. So, if we're in an academic medical center, and might be a little bit harder if you're in a role based setting. So, trying to establish a team, a workflow to improve the efficiency and the care of these patients is essential, and to reduce the burden on the patient and the family to have to communicate between each team so they can really focus on their treatment. So, as I am a dental specialist, I wanted to talk a little bit more about the role of the dental specialist on this interdisciplinary or multidisciplinary team. So, the dental specialist is often involved in the diagnosis and early intervention of the cancers. If a patient comes in with the cancer and before their treatment, often it's very important for the oral health professional to counsel on what to expect for the changes from radiation treatment. And so, things that might be discussed are the importance of maintaining oral hygiene, creating fluoride trays for patients that have dentition, and that fluoride will reduce the chance that patients develop radiation caries by improving and increasing the strength of their enamel. And helping that patient to know what to expect can be very important to reduce the anxiety and the depression, because we know that having depression can impact a patient's desire and motivation to take care of their oral hygiene, which can have quite a bit of negative downstream impact. The oral health team can help with symptom management. And it's important when we hear symptoms that we're ruling out any suggestion that patients might have a recurrence or a residual disease. And these symptoms management often include things like mouth management, pain management, and often when the mouth is dry, you might develop fungus. So we want to evaluate what is contributing to these patients' symptoms and manage appropriately. The dental specialist often has a big role in functional rehabilitation, make sure that the patient has the capacity to eat as well as possible. And this can come in the form of dental restorations, in the form of prosthetics. Prosthetics can be both for functional and aesthetic purposes. And if you're having difficulty with opening the mouth, the dental specialist will evaluate to see what's contributing, making sure it's not a tumor, and supporting patients to do exercises at an appropriate level for where they're at so that they're not putting themselves through an exercise that's promoting too much pain, that they're gradually improving their ability to open in a strategic way. And the dental specialist treats more than the mouth and the teeth. It's very important that that specialist is listening and observing to what is said and was not said, screening for any medical conditions that might need to be referred, and also for any mental or spiritual distress that is coming up for the patient. So, if you're a dental professional or if you are a patient needing support, let your dental specialist know, and they can best determine with you a plan for appropriate referral and care. I want to thank you for your time. I hope this conversation was informative. I know we couldn't deep dive into all the ways we can prevent and manage these symptoms, but I hope this discussion at least brought awareness. If you're a patient and caregiver, awareness so that you know more questions and how to prepare yourself during treatment and after. If you're a healthcare professional, how we can improve and optimize the support that we provide to patients. If you have any questions, of course, I can't answer personalized medical or dental questions on your care individually. But if you have questions, you want to reach out with your thoughts, your reflections, let me know how things are going for you. And then please do, you can find me on LinkedIn. It's my name, Jillian Rigert, DMD, MD. and I hope to hear from you. And I wish you the very best on your journey. And lastly, here are the references from today's discussion.